Welcome everyone to the meeting today. This is our presentation on men's health. St. Mark's Hospital welcomes you to today. Today we have Ben Neff and Melanie Dance, and they are here to talk about men's health. So I'm going to let them introduce themselves and get started.
Hi there, my name is Melanie Dance, and I have Ben Neff with me. Are we okay? Can you hear us all right?
Yes.
Perfect. Okay. We are both senior residents here at St. Mark's Family Medicine Residency, which is affiliated with St. Mark's Hospital. So we're a primary care clinic here. And we're really excited to talk to you today about men's health. If it's okay, I'm going to go ahead and get started. I'm going to share my screen. So let me know if you can't see this. Okay, does that look okay to everyone?
Yes.
Perfect. Okay. So I wanted to introduce a few of the things that we're going to discuss today. And basically one of the big things we're hoping to accomplish is to convince some of you who might not have seen a doctor recently to check in with one and to kind of get started on being on a healthy path for your health. So to start out with, I wanted to show you this word. Let's see, iatrophobia. So iatrophobia is an intense fear of doctors. And I'm a little bit suspicious that some of the people here today may suffer from this particular fear. So I'm hoping as we go through this presentation today that some of that might be alleviated and that you might be able to see some of the benefits of just coming to see a primary care physician. We'll talk a little bit about some preventive things, what you can expect for just an annual wellness visit. And then I'll hand it over to Dr. Neff, who is going to talk about just some really common things that you might want to come and see a doctor for. So that's kind of my plan for today. Like I mentioned, I wanted to start by talking about just kind of what a regular checkup includes. And I'm sure a lot of you are familiar with this quote by Benjamin Franklin, an ounce of prevention is worth a pound of cure. And we definitely feel that way in primary care. So most insurance companies will cover an annual wellness visit or yearly check-in. And what you can expect at that particular visit is often some tests. Blood pressure, diabetes, cholesterol are often things that we check for because they tend to be things that you don't have symptoms. So we check those at most of those visits. We offer a lot of intervention to help you stay healthy, and we'll talk more about a lot of these that are listed here. Of course, we offer immunizations, vaccinations to also try to keep you healthy, and then cancer screenings where it's age appropriate. We'll talk about all of those. So before I kind of do that, I wanted to mention why we check these things. So this is a list of the top 10 causes of death in men in particular, adult men. So if we take a look at this really closely, you can see that almost half is related to heart disease and cancer. So naturally, we're really interested in preventing those things. But there are a lot of things on this list. And at our visits, we try to kind of address these things. We want to postpone death and try to continue with healthy living for as long as possible. So these are some of the things we kind of address. And when we address these, we do it in groups. So for example, unintentional injuries is on there as number 3. What's that? And so unintentional injuries, not quite 10% of men die from unintentional injuries. So we focus on injury prevention. With down here, influenza and pneumonia, these are 2 things that we often address with immunizations. Our suicide is also a major cause of death for men, a little bit lower in the percentages, but still pretty significant. So we focus on mental health support. Chronic lower respiratory diseases are often caused by issues related to smoking. So we focus a lot on smoking cessation. And then chronic liver disease, a major cause of that can be overuse of alcohol. So we focus on alcohol in moderation and have some recommendations for that. And then we will also talk about cancer screening, since that's such a significant cause of death for adult men. And then kind of a catch-all for everything is healthy lifestyle, including diet and exercise. So many of these diseases can be addressed by, or even prevented by, a healthy diet and a healthy exercise. So we'll talk about all of those things today, but I kind of wanted to talk about these groups in a little bit more detail. So this slide is a little bit busy, but focusing on that circle there on the left, we talk a lot about injury prevention. So of course, we recommend helmets for lots of activities: biking, winter sports, motorcycling, skateboarding, really anything you can hurt your head with. We recommend wearing a helmet. Then we always recommend wearing a seatbelt. And then we recommend making smart decisions about falls and substance use in situations that could cause an injury. So of course that section might be obvious to you, but really if your spouse or significant other has been telling you be more careful or wear a helmet or wear your seatbelt, I have to say we're right on board. We recommend that also, and try to discuss that at some of our prevention visits. Let's see, over here to the right, there's this box that talks about immunizations. So we recommend immunizations, and a lot of those are given in childhood. So if those weren't given when you were a child, we recommend catching up on those. But then there are some immunizations that are also relevant when you're an adult. Every 10 years, you should have a tetanus shot. That's the one listed there as Tdap. So that stands for tetanus, diphtheria, and pertussis. So that one should be given every 10 years. We recommend a yearly flu shot for seasonal influenza, and there may be questions about that we can address at the end of the talk today, but we do generally recommend an influenza vaccine. Depending on how old you are, there may be other immunizations that are recommended. As you get a little bit older, we recommend a shingles vaccine, and that's a series. And then depending on what other medical conditions you have, a pneumonia vaccine is also usually indicated at some point. And then, of course, in today's climate, we recommend COVID vaccination as well. We can answer questions about that too if those are out there. So immunizations are an important part of wellness. And then I'm going to leave that bottom box, mental health. I'm going to let Ben talk about that a little bit later. But a lot of times I think that we think that mental health is more of a female-focused disease, but there are a number of mental health concerns: PTSD, depression, anxiety, bipolar disease, all kinds of those things can creep up in men as well and are actually very common. So if that's something that you think you might be suffering from or experiencing, that is an absolutely great reason to talk to a doctor. And we often will screen for those as well, looking to see if that's something you've been struggling with, but maybe it hadn't come to the forefront as being an issue with mental health. And then up here in the top corner, is smoking cessation and alcohol moderation. So for smoking, we want you to quit. That may be one of the most healthy things that you can do for your health and for your longevity. So if you are a smoker, please come talk to us about how to quit. There's medications, there's behavioral interventions, there's a lot of things that we can do. But please stop smoking and please let us help. And then for alcohol use, we want that to be in moderation. So for men, that's considered no more than 2 regular drinks per day and a total of 14 over the course of a week. So I've put a graphic on here that tells you what typical standard drinks are called. So depending on your drink of choice, it might be a 12-ounce beer, an 8-ounce malt liquor, 5 ounces of wine, or an 1.5 ounces of like gin or whiskey, but you should be drinking no more than 2 of those per day. So again, if this is something that maybe you're going a little bit overboard on and might need help with that, please let us know. That's something that we can help with, but that's the recommended amount of alcohol as a maximum for adult men. So let me go to this next slide. If you look there on the right, we've already talked about a lot of these. So I wanted to introduce you to the idea of the USPSTF, or United States Preventive Services Task Force. So this is an organization that makes recommendations for preventive services, preventive health care. And they are a strong enough force that generally anything that receives an A or a B recommendation on the USPSTF should be covered by insurance as far as screening or preventive measures. So you can see on there, a lot of those we've already talked about: smoking cessation and alcohol, checking your blood pressure and checking for diabetes and high cholesterol. But I wanted to focus on these bottom ones here that I'm highlighting with a pink box. These are our cancer screening recommendations. So in men, there are 3 major kinds of cancer that are fairly common. And so these are ones that we kind of talk about a fair amount. So I'll talk about these in a little bit more detail. So like I said, there are 3 kinds of cancers that we focus on for screening for men. Lung cancer is one that we like to focus on, but this is in particular for smokers. So the recommendation for screening for lung cancer is for men ages 55 to 80 who've had a 30-pack year smoking history. So you calculate your smoking history pack years by multiplying how much you smoked by how many years you smoked at that level, and then kind of adding all of those levels up. So for example, if you smoked a pack a day for 20 years, then your pack year history is 20 pack years. If you smoked a half a day for 30 years, a half a pack a day for 30 years, then your pack year history is 15 pack years. So if you meet criteria, we definitely want to do lung cancer screening. The other caveat to that is that you need we stop screening at the 15-year mark from when you have stopped smoking. So going back to how important it is to stop smoking, once you hit the 15-year quit date mark, we estimate that you have the same risk of lung cancer as someone who does not smoke. So if you can quit and stick with that, you can get your cancer risk back to a level of a non-smoker, which is where we want everyone to be. But if you're still an active smoker or within that 15-year window of since you quit, then we recommend screening, which is done with a low-dose CT scan done on a yearly basis. For prostate cancer, that's kind of a little bit of a moving target over the last few years. For quite some time now, it has been a recommendation, if you look back on that last page, it's a C-level recommendation to discuss with your doctor what's right for you as far as prostate cancer screening. So this came up, it used to be that everybody got a blood test to look at their prostate antigen, and then everybody got a rectal exam to feel the size of your prostate and see if there was nodularity that was concerning for cancer. And I think that's something that has kept a lot of people away from doctors for a while, is not wanting that particular test. And so that is no longer our standard of care. A rectal exam is generally not recommended as screening. We sometimes still do rectal exams if you're having symptoms for something, but looking for somebody who doesn't have any symptoms, we don't routinely do rectal exams anymore. They haven't been found to lead to longer lives, so that's not something that we continue to do. And then we usually will talk to you about doing the blood test. So the thinking behind that is that the prostate-specific antigen can be elevated even in patients who don't have cancer. And the reason why that can be an issue is usually an elevation in that test leads to more testing. And more testing often includes a prostate biopsy, which can have some other complications. Certainly important if it's indicated, but in general, it's a discussion about if you have risk factors in your family, other people who've had prostate cancer, symptoms, those kinds of things might lend themselves to having a blood test ordered to look to see if your prostate antigen is normal. But it's not generally something we routinely do in the absence of other factors that would lead us in that direction. And then lastly on here, colon cancer. There are 3 ways to check for colon cancer, and I've listed them right there, and I've given you a couple of pictures. So an FOBT is a fecal blood test. So that's the red card there with the stick. So this is something that would need to be done yearly if that's the way that you choose to screen for colon cancer. Often we'll send you home with one of these cards, and we'll have you put a little bit of stool on 2 spots on that card and then bring it back into the office where we test it for evidence of bleeding, which can be an early sign of cancer. So that's the first way that we do that. That is probably our least accurate way of testing for colon cancer. So this would be lowest on our list of the ways that you would get this checked. But certainly for those who are not wanting to do the other 2 kinds of testing, this is an option to get screened for colon cancer. If this were to be positive, you would need to go on to further testing. Similarly, Cologuard, some of you might have heard of this one. This is that smiley box that you see down there in the corner that sometimes shows up on ads on TV. Cologuard is a test that also is a stool test. You provide a stool sample and send it in a box that often also has a smiley face. And it's examined for some evidence of cells and things on microscopic exam that are suggestive of cancer. And if this is negative, it can be performed every 3 years and is a very good test to check for cancer. The one caveat to this is that if it comes back positive, obviously this is not a treatment, it's just a screening test. So that would need to lead to follow-up colonoscopy for treatment purposes. And so then lastly is colonoscopy. This is our gold standard. This is the thing where you have a big bowel prep to get your colon cleaned out, and then they go in with a camera. I have a picture up there in the top corner where it's looking for cancers. If they see something like what's in that picture, which is called a polyp, these are usually precancerous lesions that while they're in there, they're able to take out. So it's both diagnostic and it's therapeutic. It removes any precancers to prevent them from growing further at the same time as the diagnosis. So if that's done, depending on what they find, they may recommend a shorter follow-up period, but for screening purposes, that's done every 10 years. That is cancer screening. So that kind of leads me to my last point here, which is all of those things which can be modified by diet and exercise or essentially lifestyle changes. So there's some studies or statistics that suggest that up to 70% of those causes of death could be prevented by simple lifestyle diet and exercise changes. And I say simple with a grain of salt, but we definitely talk a lot about lifestyle changes, maintaining a healthy weight, maintaining a healthy diet, and maintaining a good regimen of exercise. So I'll go over that really briefly before I hand this over to Dr. Neff. So some of you might be in the age category that you remember the food pyramid. That's out. We don't do the food pyramid anymore. Now we have what we consider the healthy plate diet. And this is one graphic depiction of that. We have found that most weight loss is not related to increasing your exercise, although that helps, but most is related to changing your diet and what you eat. So you'll see on here, this is a regular plate. And I say regular sized, platter size is not good for you. Buffets are generally not good for you. It's a single plate. And in this case, we recommend that fully half of it is vegetables. For those of you that don't have diabetes, you can split that half with fruit. So fruits and vegetables as being half of your plate. But this really is a change in mindset in a lot of ways. We know that growing up, when we said what's for dinner, it was always the protein with the side of vegetables, and we want to kind of change that mindset to a main course of vegetables with a side of protein. So encouraging an increase in vegetables in your diet, with the caveat to that being if you consider corn and potatoes vegetables, we don't. Those have lots of sugar and starch in them, so minimizing those, but just about every other vegetable is very healthy. And then for proteins, we recommend that that's a smaller portion. And then for grains and starch, we generally recommend that on a more minimal level. And when you do eat grains and starch, we recommend whole grains rather than empty calories kinds of grains. So changing what you eat can really prevent a lot of diseases. And then kind of going hand in hand with that, maintaining a healthy weight with good exercise. The current recommendation for all adults, men and women, is 150 minutes of moderate intensity aerobic exercise every week. So this is something that gets your heart moving a little bit faster. For some people, it's a brisk walk. For some people, it's something a little bit more intense than that. And this can be spread out over the week in whatever way you'd like to spread it. So this can be, a number of minutes on the weekends, kind of focused just for that time of the week, or it can be 20 to 30 minutes a day, depending on how your schedule works. But the recommendation is 150 minutes of exercise. And then we also recommend a couple of times a week having some sort of muscle strengthening exercise regimen. This could be weightlifting, but it could also be yoga, Pilates, anything that kind of builds muscle, tends to help with your balance, and is also recommended. So that's it for my preventative portion, and I'm going to pass it over to Dr. Neff for some of the more common complaints that we get in primary care.
All right, so I think from this cartoon, we've probably all felt this way, where you go to a doctor and you feel like you're saying the exact same thing multiple times. And so we will talk about the things that Dr. Dance and I see frequently, and almost all of these things that we see are because they are also very common. And so we'll start first with benign prostatic hyperplasia, or otherwise known as BPH. This is it's a disease that affects nearly 75% of the population of men as they age. So, and it increases as you age. And so it's something that's very common, and it's something we see frequently because it affects the quality of life. On the left are some of the symptoms we see frequently. We see frequent urination, waking up at night to use the restroom. When you have to use the restroom, you have this urgency that you have to go, and then you have difficulty starting a urine stream, or you have dribbling. And then after you've finished using the restroom, you feel like you haven't emptied. And then as the disease progresses, you get a urinary tract infection. So you can get urinary tract infections. So what this is the prostate is a gland that males have that creates what's in semen. And it plays a role with testosterone and libido and things like that. And it is a necessary organ, and so this is something that is just likely to happen. So what do we do about it? The first is, when people come in to talk about it, often maybe they don't come forthright with some of these concerns because they're a little bit embarrassed, and it's okay to talk about it. This is very common, but the one that we see probably most frequently when we ask people is, how often at night are you waking up to use the restroom? And when they say 3 or 4 times, we say, okay, well, there's often something that we can do about this. So lifestyle modifications, this includes, at night, maybe not having as much to drink. We know that even just water, but caffeinated beverages or alcohol can worsen this. We know there's certain foods that can trigger it, certain spicy foods or things like that. We also know that for some people, having set times where they actually schedule a time to go to the bathroom, this actually helps, and avoiding things like constipation. And so there are some lifestyle modifications we can make. Often this isn't enough. There are medications that can be prescribed, and we often see supplements being used. One supplement, saw palmetto, is a common one, and the studies have shown in the literature that actually these supplements haven't given people the benefit that they want. For an individual, it may help, but I think it's the American Urologic Association has actually recommended against these. Medications we commonly prescribe are, one is used that you can use every day, and some build up over time. And so these are things you can ask your doctor about, and there's lots of options. And if this doesn't work, then often we end up talking about surgical options, but those have risks too. So that is a very common thing we see, and it worsens as we age. So this next slide is a valuable slide based on what Melanie was talking about, this PSA test. So I thought this algorithm was useful about how we check that PSA, and sometimes it's falsely elevated, and what are we trying to say? So when we have a discussion with patients of whether they should get a PSA, this is a study that kind of shows what our reasoning is of having this discussion with you. So if 1,000 men have the blood draw to check their prostate level, 240 will have an elevated result. Now on the right, it says some of these are false positive. So if we get a positive result, what do we do about it? Oftentimes people proceed with a biopsy or with imaging or some kind of intervention because they're concerned of what a positive result could be, because a positive result can be cancer. And then, so of the 100 people, they get a biopsy. If you look to the right, it says 20 to 50% of these men will be diagnosed with cancer, but this cancer never grows, spreads, or harms them. So they will get a positive biopsy, but does that mean all of those cancers will actually do anything and will be the cause of someone to die? And the answer is no. So then 80% of those that have a positive biopsy will choose surgery or some form of radiation. And as a result, it will save one person. It will avoid death from prostate cancer in one person. But then on the right, 5 people will die from prostate cancer even after surgery or treatment. And these surgeries have risks. You can see, 50 of those 80 men had erectile dysfunction, and then 15 of those 80 men also had urinary incontinence. So it's not an easy decision. I think it's a decision that you can make with your primary care doctor based on your symptoms and based on what they find. That's what we're here for to talk about. All right, low T or low testosterone. This is also a common complaint or a common question that we get. And the reason is because it's a very popular thing in the market, and we have a lot of questions about it. So when we make the diagnosis, it is based on 2 things. First, it is your history. What signs, what symptoms are you dealing with that show us that you could have a deficiency in testosterone? But it's not just that. It's also having a low serum testosterone level in your blood. And it's not just a one-time reading also. To have a low serum testosterone level in your blood, it's an average over 3 blood draws, because testosterone, like most hormones in our body, it does fluctuate. And so they have it do fasting, and we have you come in the morning and we check it 3 different times. And then there's a whole gradient of testosterone, anywhere from 300 up to like 1200. And so having a low level is actually having 2 levels less than 300 and having the symptoms. So what are some of the symptoms? Some are very specific to testosterone: low libido, loss of body hair, breast tissue development, small testes, infertility, hot flashes, decreased erections. And then there's very non-specific things that could be related to other causes: fatigue, depression, reduced muscle strength. And I think all of us have had those non-specific symptoms at times. I know I have. And so does it relate to low T or not? And that's what we have to find out. So we do the testing, and if you have the diagnosis, we'll talk about the treatment on the next slide. But there's also, we need to find out why. Is it just something that you just have low levels, or is it because of something else? And we do see low testosterone happen from someone who does have obesity, who has diabetes, someone who has a low thyroid, someone who has cancer, someone who's using chronic opiates or sleep deprivation. So it's more complicated than just having symptoms of fatigue and reduced muscle strength. So say you have the diagnosis, here are some treatment options. There are oral options, sublingual, there's patches, there's injections, lots of different options, but I put this part in italics. I think it's really important. So say you have a testosterone level that's like 400, where it's low, but it's still in the normal range. If we treated you and gave you testosterone, it would actually not give you relief of the symptoms that you're feeling, because your blood level is normal and you're probably having those symptoms from another cause. And so that's a really important point. Some of the risks too, all medications have pros and cons. There's risks, benefits, and most of the time there's more benefits than risks. But some of the risks we do see with testosterone treatment is men will have a decreased sperm production, because you're telling your body that when you give yourself extra testosterone, you're basically saying you have enough, and so you don't need to make enough sperm. So if you're a man of reproductive age that wants to have future children, it's probably not in your best interest. Increased red blood cell counts can happen. And that's also kind of goes hand in hand with increasing your cardiovascular risk for heart attack, a stroke, or developing blood clots. And then they have found that there is an increased risk of prostate cancer. Now, this risk is likely because you're increasing a hormone level, and the prostate, its functionality works because of testosterone and the testosterone breakdowns. So what are the benefits? There is a proven benefit of increased libido, and there is an proven benefit of people who are anemic and having a low blood count, that improving. But there's actually not a benefit in someone in their physical abilities, in their energy, their mood, or their memory. And then there's actually no benefit with erectile dysfunction, which is, I think, a common misconception. So, I mean, if you have concerns, obviously, please come in. That's what we're here for. But I think it's important to also understand what testosterone can do for you. So, erectile dysfunction. Again, this is a very common problem. I want to say, I have some statistics here actually. It's 40% at the age of 40 years old. The Massachusetts Male Aging Study said at age 40 years old, 40% of men will have some degree of impaired sexual function, and then it increases as we age. So, I mean, 40% at age 40, I think we don't realize how common that is. Now, there are two different types of erectile dysfunction. There's one that's actually where something in the body is not working, meaning the blood supply, and then there's also a type that can happen from emotional well-being. So the risks of having this, the first is focusing on, the actual functionality in the blood supply. So if you have heart disease, diabetes, obesity, high blood pressure, smoking, high cholesterol, those are all things that can affect the vasculature, the blood vessels, that can then make erectile dysfunction problematic. The second aspect is more the psychogenic side. When someone has decreased hormones that are related to mood disorders, which we'll get to, depression, anxiety, or in times of extreme stress, that's also common in that with that group, but the treatment options are different. So it's important for us to delineate those. And interestingly enough, the studies have showed people with lower education actually suffer from erectile dysfunction more. And whether that be compounded from other life stressors, it's hard to know. So what are the treatments? First is focusing on that cardiovascular health and focusing on those blood vessels and keeping them healthy. So exercise, weight loss, if you have any of those risk factors on the left, then we focus on those things. And then if you have erectile dysfunction secondary to a mental health imbalance, then we focus on that. And we focus our treatment on those different things. So medications, there are medications that absolutely work out there, but you do have to be careful of drug fraud. I think Dr. Dance and I both probably have seen cases where supplements or something bought off the internet that has the side effect or has the benefit of helping someone with erectile dysfunction or ED, it also has side effects and can be dangerous. So just talk to your doctor. There's literature out there that we have resources to that we can look up further detail to. We also have pharmacists that we can talk to if we're not aware. If this becomes problematic and we can't find an answer, there are other solutions that urologists help with, injections and surgeries and things like that. So this was a good segue into mood disorders, and Dr. Dance talked about these earlier. Depression is probably the one we see most often, but this includes, bipolar, both type 1, type 2, schizophrenia, schizoaffective, seasonal affective disorder, grief, bereavement. There's just lots of different types of mood disorders, and they're silent, and we are often not the ones to recognize them as patients ourselves, but family members, friends start to notice that maybe something's off. So if you come into our office, this is a common questionnaire that we will give people, the 9 questions on the left. So, and this is specifically for depression. There are other questions that we can talk about if anxiety is something we deal with or panic. So these questions, these are also good for self-reflection. Do you have little interest or pleasure in doing things? And then how often are you having this? Do you feel down, depressed, or hopeless? Are you having trouble falling or staying asleep or sleeping too much? Feeling tired or having little energy? or appetite or overeating, feeling bad about yourself, or that you're a failure or let yourself or your family down, trouble concentrating, speaking slowly, being too fidgety. And then the last question is thoughts you'd be better off dead or hurting yourself in some way. Now, we could take any of these individually. So say someone comes in and says, I'm having difficulty sleeping. It can be by itself a sleeping disorder, but it often can be connected with a mood disorder. So it's a constitution of these symptoms, and that's our job to try to delineate of these what's going on. And if you have questions, that's what these are silent diseases, and it's worth talking to your doctor about. Actually, there is a statistic too that a national representative survey of adults in the United States found that over a 12-month period, depression was present in 10% of the people. So even just think of the people around you, that's 1 in 10 who will have depression that year. And then it's at 21% over a lifetime. So that's 1 in 5 people that will suffer with depression alone. And that's not even including other mood disorders in their lifetime. Okay, male pattern baldness. So this is up to 2/3 of men will experience some form of androgenic alopecia, which is the other word for male pattern baldness. And it's a normal variant. It's not a disease. So myself, I'm thinning on the top. That is a normal variant. Up to 2/3 of men deal with this. So what do? There are 2 primary options I think we offer the most. Finasteride is an oral pill, also known as Propecia. And the risks of Propecia are that it can help decrease the breakdown of some of the hormones that cause male pattern baldness, but it has a risk of, yes, you can increase some risk for prostate cancer. And same thing as when you're doing testosterone medication, it can maybe decrease the sperm count slightly. So it's not perfect, but people do have, when they take it, they do see new hair follicles grow. And while they're on the medicine, they have the continued benefit. But I think what does happen though is when you go off of the medicine, a lot of the progress you've made will regress. Not suddenly, but over time. Minoxidil or Rogaine is a shampoo that people use, and it's a foam that you put on, and it's focused directly on that area, and it doesn't have the same risks with regards to the prostate and with the decreased sperm production, but it does have other risks. It was initially a cardiovascular medicine used for blood pressure, but because it's used just on your hair and it's a topical, those risks are kind of less so. I have seen in one patient where the shampoo came down his face and he got a rash over his face and forehead, and he just wasn't a good candidate for the medicine afterwards. But same thing, once you stop using this medicine, you probably also lose the benefit. Now, what about genetics? Now, I think we've all probably heard, oh, it's your mom's dad. Now, the truth is we don't know. They do say that in twins, they did a study between identical twins and fraternal twins, and they found that 80% of them were found to be genetic, but there's still 20% of the twins that they couldn't reason out if genetics played a role. So the answer is that yes, most likely genetics are playing a role, but not always. And so I guess we can't know for sure. Okay, back pain. This is something that's obviously common in men and women, but I put it in men's health because, as in the quote above, it says acute low back pain is the first reason to seek medical care as an adult. And this is absolutely true for what we see. Now, the disease course for back pain, I think it's something that people deal with frequently, but the problem is it's 31% of people will not fully recover within 6 months. And so it ends up being a longer duration for many people. And it's also a very frustrating duration because it's a slow course. So what do? When someone comes in with back pain, our job, Dr. Dance and I, will first focus on what things are emergent. Do you have signs of something happening that you need to go to an ER for, or you need urgent imaging? And most of the time the answer is no, it's not emergent, but things like if you aren't unable to pass stool, if you're unable to urinate on your own, if you have severe weakness to the point where you can't lift your foot off the ground, if you're having numbness in your groin, and it's common to have some of those, but if you have all of those, then yes, it is more of an emergency. More often than not, your back is spasming as a protective mechanism because you have injured it, and it doesn't want you to further injure it. And so what do we do frequently is we calm down those muscles. We do things to help tell your body that you will not injure it again. So physical therapy, those rehab exercises, stretching, calming it down with anti-inflammatories, with ice, with movement, with hydration. Bed rest has actually been shown to worsen outcomes because if you're not moving, you're not telling your body that this injury is going to get better and that you're not helping those muscles relax. And by doing this therapy and those exercises, you're strengthening your core, and that is often enough, but it can be a prolonged course. Complications we see is that it can be anxiety provoking because it can last a long time, and the people really worry about, what if this comes back? This was really detrimental. It took me out of work and it took me out of these different things. And so exercise with some core strengthening can do quite a bit to help prevent further illness. All right, I have two more, and then we'll get to questions. So, considering a vasectomy, I thought this cartoon was hilarious. I have 3 kids myself, and I think we've all probably been in the car where, this gentleman's facing the same question. So vasectomies, it is a sterilization procedure. It's done in office, and what's unique about it is no sedation is required. You're awake for the procedure. If they can give a calming medicine before, similar to like going to a dentist where you take a pill, but you're still with it, you're just more calm. Some of the benefits are that it is cost effective, and I think in office probably for a cash price is $200 to $300. And then return to work, if you have this done on a Thursday or Friday, you usually can return to work by Monday. And that's not like you're in bed over the weekend, it's just as a precautionary measure in case something goes wrong. Now, complications, we don't see very many complications, to be honest, but there are people who have chronic testicle pain after. And another complication is maybe it's not successful and someone gets pregnant. Most often from that is because they didn't wait long enough after the vasectomy before resuming sexual activity without some form of protection. The vasectomy works, but it works after a couple months. So with regards to the chronic pain, that is something that is not common, but urologists see it frequently, and it's something you should just have a discussion with your doctor about. And we get the question too as, oh, well, I could just get a reversal later. And the answer is that yes, that's an option, but it's not a great option. Vasectomy reversals can happen. They're usually a procedure where you're probably going under general anesthesia with a urologist, and it doesn't always work. And so it's probably better to never do the vasectomy if you're still considering having children in the future and doing other methods. All right, so this goes right along with what Dr. Dance was talking about. The quote on the right, I heard this morning with a patient I was seeing. Said, I've always been healthy. I never needed a doctor until something happens. And usually that something is not a good something. So a gentleman I saw just a couple of weeks ago had a very bad stroke. And he said, I've always been healthy, and now I'm on these medicines. And unfortunately, it was probably something, we don't know if it could have been prevented, but we could have taken some measures to mitigate that risk. So the silent diseases that we see, and these are just some of them to name a few, right? Obesity, diabetes, high cholesterol, sleep apnea, high blood pressure, depression, substance abuse, cancer. These are all things that we see regularly, but we are usually seeing them when an adverse event is happening, right? When someone maybe didn't have their cancer screening and now they're coming in with a more advanced cancer. When someone's had high blood pressure for a really long time and they present after having a stroke. Sleep apnea is one that we haven't touched on thus far today. We see it frequently, and it's often someone else that they live with that's telling them like, hey, they snore at night. And the problem with sleep apnea is it causes strain on your heart. You get pulmonary hypertension, and it can lead to depression. It can lead to erectile dysfunction, and it can lead to that strain on your heart can lead to further damage later into heart failure and things like that. So that is one that's that we do ask about frequently, but it's not a part of the preventative task force services. So it's one that we recommend you thinking about. Like cholesterol, diabetes, obesity, you will hear about those things if you come in, but sleep apnea is not one that we pick up on a lot. Substance abuse, Dr. Dance talked about alcohol as well as smoking. Something that we also see is vaping. We have both had patients in the hospital who've had vape-associated lung injury, and then things like marijuana use on that's not nicotine. We've also seen where marijuana use gets out of control, and they have symptoms based on that. So hopefully that answers some of your questions and can give you guys give all of you some information on some of the things we commonly see, as well as what we do in preventative visits. We would like to open it up to questions. We have, I think, until 1 o'clock, and so I think the chat's open, but please feel free to just speak up through the microphone as well. Okay. Can I stop presenting?
Yeah, I think so.
See the chat box.
There we go. I just had to stop presenting. Sorry about that.
Can you see the chat box, Dr. Neff?
Yes, we can. Thank you.
Yeah, there's a couple questions there for you.
Okay, so I'll take the first question and maybe we'll just, Dr. Dance and I can alternate. So the first question about smokeless tobacco. Yeah, it's a great, it's a great question. Smokeless tobacco is one that nicotine is what causes is what our body gets addicted to. Tobacco has its own risk, but nicotine also has a risk. It elevates the blood pressure, it puts a strain on your heart. And that's also what we see with vaping. And we have had, last year, we did have a very young person in the hospital with vape-associated lung injury. And there was some severe damage to his lungs. And he did okay, but it's not benign. And I think it's something we should talk about even with youth. So. All right, here's another.
We have another question in the chat about breast cancer in men and testicular cancer.
Hear me now? No?
Okay.
Melanie.
You can hear me speak?
Now it's double because you're probably both on. So one of you needs to mute.
Okay, I'll take Ben's screen. Can you hear me now?
Yes, let's try that.
Okay. So I'll take this question about breast cancer in men and testicular cancer. So men can get breast cancer. It's certainly not as common as breast cancer in women. And there aren't current recommendations for mammography in men unless there is a mass noted. The unfortunate thing about this is that does mean that breast cancer in men is often diagnosed at a later stage. But if you feel any sort of mass within the breasts, and especially if you have a family history in your family of people with breast cancer, but specifically any of the BRCA mutations, it's definitely worth having that examined. And there is mammography for men that is done in the case where we are suspicious of something. Generally, routine screening is not recommended for men at this time. And then for testicular cancer, this certainly is another thing that affects men. And often it can affect them at a younger age. There has been some debate about whether or not primary care physicians should teach men regular testicular examinations and how to self-examine. The last time I checked, I believe that was an indeterminate guideline as to whether or not regular self-examinations should be performed. Certainly in men with a history of testicular cancer, I do recommend some self-checking and making sure that you don't feel any abnormal lumps or bumps. Generally, this presents as a painless lump in the testicles. So kind of knowing your own body and where you are is very important. And if you notice any sort of symptoms, that would be something to have examined. We often will do follow-up testing on this with ultrasonography or other testing if you do find something abnormal. And then it is also a little bit controversial as to whether or not men should have regular testicular examinations by physicians. This is kind of patient and provider preference with joint decision making. If you are concerned about anything that any abnormalities in your testicle, or that there may be something different from other men, that's something that I would recommend an examination for. But again, routine testicular screening is not on the list of recommended tests for everyone. It tends to be self-selecting for symptoms or family history, things like that.
I think the only thing I would add to would be testicular cancer often comes in what we call a bimodal distribution, meaning we often see it in younger. It's probably the most common cancer we see in young males, age 15 to like 26, and then it will present later in life. But usually the middle life ages of men, it's not as common. There's another question here about suggesting daily baby aspirin for stroke prevention. So excellent question. And this is something that's actually changed frequently. When you come in to see your doctor, it is something that we base on. We decide if you're a candidate for someone who should take a baby aspirin based on your risk factors, but also based on your cholesterol panel. So your cholesterol panel, that we can calculate what your risk of having what we call an event over a 10-year span. And when we calculate that risk, certain populations, it says, you might not need a cholesterol medicine, but you probably should be on an aspirin. And aspirin is something that they use for stroke prevention. It also has its risks too, because aspirin can have someone that leads to have a bleeding incident, such as a GI bleed or even like a stroke where they have bleeding in the brain. And so it's not benign. It's not something that we tell blanketly, hey, you should just take an aspirin like we used to. We now have more selective measures, and it's based on your risk factors as well as your cholesterol panel frequently.
Okay, the next question I see in the chat looks like a question about the shingles shot, which insurance does not cover. So some insurances do, and sometimes it's a determination of where to go to get it the cheapest. So doctors' offices offer the vaccine, pharmacies offer the vaccine, the health department offers the vaccine, and sometimes there are ways to get it covered or to get it partially covered, depending on what your insurance looks like. But you're right, it can be a really expensive vaccine. It is recommended for all patients over age 50, but you do find that it's more important in certain conditions. Patients that have diabetes or rheumatoid arthritis, patients on chronic steroids tend to have a much higher risk of having a shingles outbreak. Now, shingles outbreaks can be just limited to being uncomfortable. For those of you who've had shingles before, it doesn't feel great, and most try to avoid that if they do get a shingles outbreak. But there are some more serious complications, especially if you end up with a shingles outbreak on your face or near your eye. There have been some reports of blindness from shingles outbreaks. So it's definitely something that we want to prevent, but I want to definitely say that I understand the battle with trying to get this vaccine, especially since in the last few years there was a vaccine that was recommended, and then a second vaccine came out that was found to be more efficacious. So people were recommended to get the updated vaccine even if they'd been previously vaccinated. And I do also want to say that the vaccine is still recommended even if you've had an outbreak of shingles in the past. it is recommended that you still get the shingles vaccine. So I hear the frustration. It's still a recommended vaccine. And I definitely push that a little bit more if you are somebody who is in an immunosuppressed sort of state from using steroids, having a chronic disease, having diabetes. You're just more likely to have a shingles outbreak, and they can be not just uncomfortable but serious. I'm seeing on there that also some people have had reactions to the shingles vaccine. Certainly, there are reported reactions to a lot of vaccines. Reactions that I have heard come up with the vaccine. Certainly, you can have a local site reaction. That's present with any kind of vaccine. You can have some discomfort and redness. It can even sometimes look like an allergic reaction at that spot, but is usually a vaccine reaction. And that's kind of related to any vaccine that you get. Specific to the shingles vaccine, I have heard of some shingles reactivation episodes, but it's my understanding that that is much less common with the most updated vaccine, which is Shingrix. The Shingrix vaccine has had significantly fewer of those reactions. So I wouldn't say a lot of people, but certainly some people have had reactions. Less so with the updated vaccine. It's a recombinant vaccine, so it's at a little bit less risk. And so, you know, it's weighing the benefits, the pros and cons of getting vaccinated. But generally, our recommendation is to be vaccinated if you're over 50.
We don't see any other questions in the chat, but does anyone else have a question they would like to talk about? All right, there is a question. It says, can you talk about finding a good doctor? I actually do think that, you know, I bet Dr. Dance and I are both approached frequently, even by neighbors and people in our community who ask about finding a good doctor. And the response I would have is, come see us. But no, in reality, I think finding a good doctor is about finding a good fit. And I think we both recognize where we've had patients where we weren't the best fit for them. And that's okay. And we don't take offense if, you know, you come to see us and, you know, our style of medicine was not your best fit. And that's okay. We all come from different walks of life, right? I trained at an osteopathic school in Iowa. I'm a native of Salt Lake, and I know some of the things about Salt Lake. Dr. Dance, she trained in San Francisco, but is also from Salt Lake. So we come from different experiences, and that's part of what makes us individually good at what we do. And so we fully expect people to change if it's not a good fit, but I would also never be offended if you asked me for recommendations. You know, I've had frequently where someone said, hey, can I see a female provider for this issue? And the answer is absolutely. That's what we do. We, as family medicine doctors, we also know a lot of specialists. We rotate with a lot of them. We spend a lot of time and we interact frequently with them and just call them on our cell phones. So if you want to know, hey, who's a good dermatologist that you've worked with, or who's a good GI doctor for my daughter, right? That's something we can absolutely help with. That's part of what we love about family medicine is the networking and getting to know people in the community.
So I see another question in the chat for men's health. What type of doctor should I be looking for? And it's asking, is family medicine the best? Could be, not necessarily. So it kind of depends on what you're looking for. Family medicine is a specialty that takes care of people throughout the lifespan. So from birth all the way up till death. So we kind of see all age ranges. So family medicine is a good place to get health care if you are anticipating that you might want to stick with the same doctor for all of your life. Or if that's something that you want consistent health care for all of your family members that could be seen in the same office, family medicine is a great fit. Some other practitioners that see men in general, certainly adolescent health can sees up through about age 20, even though it's categorized as adolescent health. We don't anticipate there's very many on this forum that fit into that age range. Internal medicine also sees adults. They do not see any children. Internal medicine otherwise is very similar to family medicine. It's just a little bit more limited in age range. And internal medicine generally is all adults, from young adults up to older adults. And then geriatrics also is a specialty that sees a lot of men. This tends to be for retirees and on up. So people over the age of 65 sometimes will be interested in seeing a geriatrician that specializes in elder kind of medicine. And all of those are great options. And I know St. Mark's has clinics that include all of those providers. So again, like Dr. Neff talked about, it's really finding what is a good fit, which provider fits your personality, kind of fits how aggressive you are about different kinds of testing, who listens to you and meets your concerns. But there's not necessarily a right answer. Any of those specialties would be great ones to follow up with.
All right, it's 1 o'clock. I don't know if there's any final questions. Please, I believe Andrea or Kim, who've kind of helped put this together, they can reach out to us. We'd be happy to help. And then we can absolutely provide our email addresses here. Melanie and I will put them in the chat. And please just feel free to reach out if you have any questions, okay? Oh, I just responded to. Okay, thanks everyone.
Thank you all for coming. Sadie has put the link for healthy lifestyles in the chat. So if you haven't done that yet, you'll want to go do that really quickly before the meeting ends. Last call for any questions in the chat. And I want to thank you all for attending on behalf of St. Mark's Hospital.